Good afternoon, everyone. I think we'll make a start. Welcome, everyone, to this afternoon's presentation. My name is Jenny Phillip. I'm the Chair of Palliative Medicine at the University of Melbourne and St Vincent's Hospital, and with appointments at Peter Mac and Royal Melbourne. And I'm really proud to be hosting this event on behalf of the Palliative Nexus Research Group. To begin, I wish to acknowledge the traditional custodians of the land. I'm on the land of the Wurundjeri people of the Kulin Nations, and I pay my respects to elders past and present, and also wish to pay my respects and acknowledge any Aboriginal and Torres Strait Islander people who might be in the audience today. As some of you will know, we began this series called Perspectives back in 2020 when we were all locked down and felt a bit isolated, and it seemed like a good way of being able to stay together as a field and reach out to each other. And we have two formats, and today I'm really excited that we are doing an in-conversation format where I'll do an interview, if you like, but really broadly have a very wide-ranging conversation with a key leader, thinker, and doer in the field, and I think that we're in for a treat today. So it's my pleasure to introduce Dr. Chris Sanderson. Chris originally trained in Adelaide and then worked in Sydney for many years. At the point, and this is her bio that I'm reading, at the point where she was starting to wonder about what was next in life and getting very sick of the daily commute, she began to do locums in regional and rural areas, and to her surprise, found a renewed joy in clinical palliative care. However, when Chris got to Alice Springs, she realised she'd really found her place in the sun, if you like, and the place where she wanted to be the rest of her time in palliative care. And that was about 5 years ago. And she says that her only regret now is that she didn't come to Alice much sooner. So it's my pleasure to welcome Chris, who is, I guess, entitled her conversation today, Gone Bush, Reflections on Doing Palliative Care in Central Australia. Welcome, Chris, and thanks for coming along. If I could begin, Chris, can you tell me a bit about your career in the years prior to this big momentous decision that you made?
So perhaps before we get going, I should be acknowledging the country that I'm on too, which is Arundel land. And acknowledge the elders past, present and emerging, and all of the other Aboriginal people who have welcomed me here to Central Australia. Yeah, my career, well, it's probably an ordinary sort of palliative care career, really. I mean, palliative medicine's a fantastic kind of diverse way to earn your living. But I was a late starter. I started medicine, ran away, did other things for about 15 years and went back. So actually from starting medicine to graduation was 20 years at Flinders.
So ran away, that's just you just threw that in, ran away. What did you do?
I was too young. I was much too young to do medicine. And in retrospect, the thing that I realised, well, one of the several things that upset me was actually the way dying people were being treated. And I found it very hard. And it was really a long time before I realised what I wanted to do in medicine. Palliative medicine didn't really exist when I first started, but I came back specifically to do palliative care. And so that made medicine much easier because I knew where I was going, what I was doing. It was my kind of guiding light that got me through everything. It wasn't so easy because I was a single mum, and a bit older than everyone else. And I was back in my old medical school 15 years later, which was a very strange experience. But then trained in Adelaide at Doorhouse, got through the physician training, and then decided I really wanted to have a bit more of an adventure. So I went on to Sydney for a while. So, and in Sydney, I worked at Calvary predominantly, but in a few other places as well, and had a bit of a research career. I love the research, but I would have to say I'm probably a failed researcher, really. I've got the PhD that I didn't finish, and I'm not so good at stats. So as soon as the data comes in and all the authors are corresponding about like how to interpret the data, it's like, oh my God. So anyway, there you go. I try and keep up, but I was starting to feel a bit tired. I thought, oh God, keeping your CV up to date's hard work, and it's it gets tricky. So I did a lot of clinical work in Sydney, both North Sydney, Calvary, and then I was just getting a bit just jaded, just a bit kind of everything was familiar, and wondering really was wanting to go, and a big commute as well, and it was tiring, and I just the juice was gone out of it. So when I started doing locums, that got interesting. It got interesting again.
Well, let's hold that thought for a moment, because I want you to I think you touched on it, but tell me what palliative care was for you when you first started out in it.
Oh, palliative medicine, yeah. Palliative medicine's just, it's the best medicine of all, really. I mean, it's your last chance to get things right for people. It's totally holistic. It's really so patient-centred. Just to help people navigate, to use all our medical skills to help people get the best out of what they've got left, and to have the knowledge to make decisions, and to be able to influence change too, because I've always just been a bit of a, wanted to improve things, like if there's a chance to improve something. So to be able to advocate for change and support people and help people through the system has always been the great pleasure. So yeah, I've loved my palliative care that way.
And it gave you that?
It's always given me that. But looking after patients is always good. It's always been the best part. Yeah.
And so was there sort of like, was it just, well, not just so many things happening at once, or in time, or
I think working where I was working, it's a big field. There's a lot going on. There's a lot of super specialty oncology. I was just talking about this with my registrar today, quaternary centres, that the patients just disappear off to the here, there and everywhere into the private system. And, the GPs, how many times you have to ring GPs to try and get them to come to the nursing home and see their patient. The frustrations of a really fractured, highly privatised, very money-focused, not very people-focused healthcare system just get tiring after a while. You're trying to get people through, and it's kind of like the whole system's against you, really. Yeah.
Okay. And
I was getting to that point.
yeah. And I get that, and I get the sense, I suspect that that feels a bit familiar to a number of us. So then you did a locum.
I did a few locums. I think my first locum actually was in Brisbane, which wasn't so much of a shock to the system. But it's always interesting to go somewhere else. And then I discovered the joy of being a locum is like, you're brand new. They're so glad to see you. You get to do all the nice stuff and all the boring administrative no one expects you to know anything about. So it's actually fabulous. So I started to really enjoy it.
You don't have to write the business case.
No, none of that. No one even bothers you about that stuff. So you actually just get to look after patients and just sense all the different see all the different ways that services run. So I started doing more I'd done a little bit of regional stuff always as a registrar anyway. So I'd been going up and down to Coffs Harbour. I went there. I started going there as a locum. Gippsland, I worked for a while on and off. So I was going down there, and Launceston. They were the main ones I was going to. I also visited my alma mater at Flinders at one point.
And so you didn't mind travelling around and living in different spots? That was sort of...
I love it. Because you
put down roots in
joy of
a period of time. Like, could you sort of get into the community in a I'm not sure how long they were, but
no, not really. You don't ever. I guess as a locum, it's fairly minimal how you connect with people. You might make a few friends in the hospital, but yeah, that's true. You are a little bit of a ghost in the machine. You're just kind of not very connected. That's true. So. But it's nice to go and come home again and then have a complete break, and just say when you work and when you won't work and that sort of stuff. And you do, if you start visiting a service regularly, people are pretty happy to see you again, or not, maybe. So,
But it was
and
liberating in lots of ways, it sounds like.
sorry,
So it's quite liberating in lots of ways.
very liberating. It was. It felt very liberating. It just felt like just getting off the, you know, off the track a bit, and I enjoyed that a lot. I just enjoyed the freedom of that, and also really curious to see all the different ways services run. And I started to get some ideas about, I guess, the range of ways country services are set up, and different processes that happen there. So, yeah, so I did that for a couple of years, and that was fun. I was enjoying it, actually.
And that took a bit of courage, actually, to do that, I would think, just to sort of step out of the system and do that.
Maybe. No, I don't know. I was still trying to do my PhD at that point, so I thought I was funding my PhD. That was what I was telling myself. Yeah.
And so then you made the decision to move to Alice Springs. What was behind that?
Well, I came here on a locum, and I had been quite anxious about coming to Alice. It wasn't somewhere that I felt was an easy place to come to, obviously, and I suspect a lot of people would have that sort of sense about here. But I knew that the doctor here, who's someone I knew, I'd actually worked with her many years earlier. I knew she was unwell and that they needed cover, and they were having a lot of VMOs coming through, which gets to be the situation in a lot of country services. They become reliant on VMOs and locums and stuff. It's very, very hard to run a service that way. And so I'd heard that she wasn't well. Mark Bowie actually mentioned it to me and said that I should go. And I was kind of like, oh, I'm not sure. But then
Mark's
my daughter...
hard to resist, though, isn't he, when he says something like that?
But my daughter was actually working in a remote community here in Western Australia, actually, at the time. So she's a social worker in Warburton. And she just said, Mum, just go. For God's sake, don't be ridiculous. They need you. So I went, all right, okay, I'll do it. And literally, I stepped off the plane, and it was just, it was quite overwhelming, the sense of like, wow, this place is incredible.
So tell me about that. Tell me about that sort of sense of when you first arrived.
It feels different. It feels familiar. Like, as a South Australian, you know, we used to holiday up in the Flinders, so I've got that real sense of the sort of, you know, the Central Australian kind of flavour a bit, but you know, and I love that. That feels like coming home. You know, it's the big blue sky. It's hot. It's dry. It's red. It's amazing. It's so beautiful. But really, as soon as you come into town, it's just, yeah, it's quite it's quite an extraordinarily physically beautiful place, Alice Springs. I don't know, for people who haven't been here, it's remarkable. Quite a stunning physical landscape. The town itself is full of Aboriginal people everywhere, and you really very much feel like you're in an Aboriginal town. Like it's not our place. And then coming to the hospital, I just really fell in love with this hospital straight away. It was the most welcoming and interesting and supportive place, and that was an instant kind of thing too.
How is that sort of sense of welcome and support conveyed?
Well, the medical director got in touch with me and said, oh, I'm so glad you're here. Can you help us figure out how to do advanced care planning better? That was like day one. And I thought, oh, okay. No one's ever asked me that before. And then it was just like, well, what do you want to do while you're here? Just tell us, you know, what you want to do. Just tell us your thoughts. So it's been a very inclusive, welcoming kind of environment. In terms of the way this place functions, people are here because they've chosen to be here. They're here because they really like working here, because this is the kind of place that fits them as doctors and nurses and allied health. So it's very collegial, very supportive. There's no silos. There's no fuss. Everyone is just kind of, you know, on a level. It's all shoulder to the wheel. How do you solve this particular problem? It's an incredibly helpful and encouraging place. yeah, it's so. I mean, I've never worked in a place that is that's quite like this, and as welcoming and receptive to palliative care.
And this is a little off script, but you said, people have chosen to be here, or people are. So what are the characteristics of the people who have chosen to be here? I guess you've sort of said that, they're democratic in that way. And what else?
Well, you're not if you're interested in money or profit, this is not the place you want to come. There's no private anything here. People are generally very connected to the place, have a real sense of pride and, pleasure in this part of the world, build very strong relationships within the community, very usually interested in and positive about Aboriginal culture. And that's a really defining kind of shared interest, like, how do we do this better? How do we get this right? A real consciousness about the environment that we're working in here. And I think that sort of imbues the whole hospital in a way that's quite unique to me, and the whole town, actually, of Alice.
Wow.
And that's, so the thing about Alice is it's a crossroads for a lot of people who've worked in a lot of remote communities, and people who've maybe worked remote in all kinds of ways. It might be health, it might be arts, it might be education, it might be kind of infrastructure, trades, might be running stores. Often, once you've done that, you may not want to go and live, in a suburb again. So living in Alice might be what you end up doing. Or people are based here and they come and go to remote communities. And they're people who've often got very strong relationships within those communities. So a real appreciation of and personal connection. So, and that just kind of, that characteristic, those kind of relationships just flavour everything that happens around town. It's not all like that, obviously. I mean, we've got a mixture of, all kinds here, but that's a really strong characteristic of this place, is there's lots and lots of people who love being here, who know this area well, and who kind of form a real network of support and connection. And I mean that not in a hooey sort of way, but it's a really practical thing, like to know who's in the clinic in Yuendamu and which nurse is there now, and, that the childcare team is there this week, or they're not there, or they're not there going there anymore. Like it's the real absolute practical knowledge of how this place works and how to get from A to B and what's happening for people. So it's just a network of information and kind of connections that grows the longer you spend here. So it's a fascinating place to work.
Yeah. And you probably answered it, but the sense of community is
yeah.
I mean, it's not completely the same as what you were just describing, but there's a strong sense of connectedness with community, with all community.
Yeah. So I guess people, like, I know the junior doctors come here and they have a lot of fun, and a lot of them actually, there's a reasonable proportion of people actually stay or want to train here because they really get to like it. There is a really nice community in town, and quite a diverse community too. Like, it's quite multicultural, and it's not just health people. I mean, there's very much, this is a hospital town, a health town. It's actually a renal town, really, I think, in many ways.
So I was going to ask that. Can you tell me about the hospital? Like, how big is it? What sort of things can you do there? What can't you do? That sort of thing.
So I think it might be about 180 beds. I'm not sure. So it's a sort of a mid-sized hospital. Pretty big. It's grown, I think, in probably the last couple of decades. We probably need a bit of a rebuild, truth to tell. But it's run by general physicians, run the medical side, so it's all general medicine. We lack quite a lot of specialist. We've got big holes in our sort of specialist mix. Things like neurology, for example, we just don't have and can't access. We've just got a respiratory physician. It's really hard to get the complete set. Very hard to get the complete set, but we have fantastic general physicians. We've got surgeons. We've got a 10-bed ICU. There's a really good, very busy ED. There's a mental health ward, drug and alcohol. There's an oncology unit run predominantly by VMO oncologists providing chemo. We struggle with rehab. We don't have aged care. We've got a peds ward. There's ONG here. I think that's about it. And there's us.
Yeah. You have beds?
We've got a 10 rooms in our unit. Well, I'd say we're staffed for 8 beds, so we run it as an 8-bed unit. And we see results as well.
And if people needed, say, specialist surgery, I'm not sure, like ENT or I don't know.
We've got ENT. So we do have, we have ENT. Fancy surgery. So, look, it's a huge thing for us is actually decisions about sending people, transferring people, because there's a lot we can't do. So we do have an MRI here, but, obviously we don't have a lot of surgical procedures can't happen here. A lot of radiological stuff can't happen here. Nuclear medicine is not a thing. We may get a radiotherapy at some point. That will be very interesting. So there's holes, and what that means is we're always deciding about when we send people and how we send people, if it's the right thing to do. And sometimes they just tend to go on the conveyor belt, which is a problem. Because that means people die interstate or they come back ventilated for end of life.
It sort of puts a whole layer of I don't know, extra.
It's a layer of decision
making about whether this intervention is the right thing to do or not, or what's the benefit.
Yeah, it makes you really. It does make you really think about that. And that's something I really try and focus on all the time in our M&Ms and in our teaching in the hospital, that's a really key moment. Sorry, my lights tend to go on and off here.
That's all right. Just mixing up. That's good.
So
it is interesting because that's like a core part of palliative care, but it just raises the stakes, doesn't it?
Absolutely raises the stakes hugely. So, and because we don't, like our cancer medicine, I think is, we're not fantastic. There's not a fantastic amount of cancer experience or literacy in the hospital. So often those decisions kind of like, I want to get involved in helping decide whether someone is appropriate to transfer, because even before they've got a diagnosis, it's like, that person's never going to get treatment. Don't put them on a plane when they want to come back. There's no point in that tissue diagnosis for this person. It won't make a difference. So, and we don't have the oncologist here to have those conversations, so it kind of falls to us a bit. So I'm always pushing out of my tram tracks here.
So thinking about that, what would a typical day look like for you, Christine? A work day.
A work day, yeah. So they can be anything. Like we do have a bit of a structure. Obviously, I try and have the ward round in the morning and the consults in the afternoon, that sort of thing. We don't do much outpatients, but basically we are able to be very flexible. So if we get a call from our retrievalist or from ED to say someone is in ED, we can just go straight there. At the moment, I will start my day with a little huddle. So we have our huddle. We kept our COVID huddle going because we liked it so much. So we have a huddle in the morning.
Who's in your team? I didn't ask you, sorry. Who's in your team?
We're a small but perfectly formed service.
Yeah.
So we have our inpatient units. We've got our nurses here, nurse manager and whoever's on the floor, two RNs at a time. Registrar and an RMO in the inpatient service and myself. We have a social worker who's the hospital social worker for our team. And then our community team is 2 nurses and a registrar.
Right, great.
So we're small and lack a few things, but we're a good size in a way because it means we're like a little football team. We just can pass information and everything just passes between us almost without having to have a lot of communication and processes. We all know everything about all the patients, and I really like that. So we have our huddle in the morning, super quick. It's just what happened on call, what's going to happen today. And then I'll whiz around, do the ward round. And then at the moment, we've got a patient dying at home who's about 30 k's out of town, and I've been seeing him every day. I wouldn't normally see the home patients, but this guy has been a really challenging patient. So just to explain a bit about that, just because it gives you some context, he's an Aboriginal man who's from, one of the very significant families in town, but he's had a lot of mental health issues, and he's dying of peripheral vascular disease, which is pretty awful. Didn't want an amputation. And he just hates hospital so much, because for him, hospital is a place where Aboriginal genocide is continuing. That anything we do to people in hospital, Aboriginal people die in hospital, and he, if you flip the, binoculars around and look at it from his point of view, it's not wrong. A lot of Aboriginal people do come into hospital and die very prematurely. So he just sees that all as, he's totally terrified, basically, of hospital treatment, and wouldn't take anything by injection. Despite the fact he's got a drug and alcohol history, we've had to work so hard to get him to take any medications. So I've been seeing him every day at home, out on the outstation.
Would that be uncommon that you'd need to do a home visit, sort of extending outside town?
No, that's not uncommon. We've got our town patients, and then we've got our sort of surrounding areas. So we can do it, if it's an hour there and back, that's fine. There's a region beyond which we actually have to book a visit with, sort of, like actually have to arrange it. So if it's a half day or a full half day or a day, to get there and back, that's more of a problem. But we'll still do that. Like we'll go.
Sorry, I interrupted you. Do you have to fly ever, or is that sort of not?
Yeah.
That's
so we fly to Tennant Creek, and we don't fly much. We'd much rather go by road if we can, because normally we can just toss stuff in the ute. We can have equipment with us. If you go by plane, you're sort of stuck when you get there. You've got to find a vehicle somehow, and you've got to wait for the next flight back. So actually it's very inflexible. We do our Tennant Creek visits. Every couple of weeks we'll do an outreach to Tennant Creek. So that's a fly-in, fly-out. But generally we'd prefer to go by road if we can. And we've done a few, we do some outreach stuff. So we had a paediatric patient in Utopia, which is about a 3-hour drive away. And when we realised how tough the clinic was doing it, Fred and I just kind of went the next day. We just rescheduled the diary and just went. And I'll never forget, the nurse just burst into tears when we arrived. She was just so glad to see us.
Yeah. And do you have to, I don't know, can you change tyres and things? Are you good at that?
Fred. I go with Fred.
And Fred's masterful.
I can change tyres if necessary. I haven't done it for a while. There's a few safety procedures about going and coming back, and checking in and all that stuff. But yeah.
Wow. And so you might do a home visit, and then what else would your day be? Would be sort of responding to urgent calls, or
it's just chasing up the consults, checking on people, being available by phone for the juniors, because I don't, I can't be everywhere at once. So they'll ring in and check in. We get calls from about our patients who are in remote communities or some of the remote nursing homes. I've got a few projects on the go, so I try and allocate a bit of time to that. The day certainly flies by. So it's a mix, and it's not a very controlled mix. There's a bit of a schedule, but the schedule never seems to stick. I quite like.
And do you have to, is there much after hours stuff? Do you have to?
We have a 24/7 on call, which is generally not busy, but what it allows us to do, and when I'm on call, I have to do the weekend ward round. So I'm on call 1 and 2. So I alternate with the registrars. They do 1 and 4, I do 1 and 2. And I'm second on call when they're on. And there's only me as a consultant. So that is a pretty continuous load at the moment. But the on-call is basically phone cover, but it does allow us to, in an emergency, we can get someone through from ED straight into the unit after hours. We can arrange for that. We can go out and see someone in a crisis. We can set up a syringe driver after hours. I'll go out with the nurse and we'll do that.
Okay.
So we do all those things. But it's not so busy that, you're doing that every night of the week. Yeah.
And so what would be, so thinking about what you've described, the magnitude of the differences between working, say, in Sydney, northern suburbs, in palliative care services versus working in Alice Springs, what would be, maybe it's a silly question, what are the biggest differences? Or how is it so different?
It's
the problems
different.
are probably the same,
yes and no. They aren't actually the same. You see stuff here that's completely different. So the medicine and the illnesses and the problems you see are completely different. That's probably the main thing, the first thing. So the cultural setting, dealing with Aboriginal patients and the terrible health problems that people have. So the first time that I saw a 25-year-old woman that I'd never met before, hadn't previously been referred to us, was airlifted in from a remote community, dying in extremis of bronchiectasis, which is HTLV1 positive, which is a disease you just don't see anywhere else. And it just causes these horrible respiratory deaths. And she, the clinic had seen her. They'd said, we can't do anything. MRAC had picked her up and said, she's not for ICU. Should she go to palliative care? I'd say, yeah, all right. And I come in and see this woman with her partner and her little baby there, and I think, oh my God, I was fairly new here then. It's shattering, actually. People are so young.
The medicine is astonishing. That sounds like, I don't mean that in a glib way, just the witnessing what you see.
Yeah. 26-year-old who doesn't want to go on dialysis, and so her family take her back out to teach her, and she dies on a mattress under a tree out there in a sorry camp for another family member. It's beyond, it is just a completely different world. In terms of the health issues that you're facing, and then dealing with them. So how you can manage people in communities, learning how to figure out what you can do for people who are in a very remote place with very little healthcare and with very little sort of shared understanding about, treatment and management of health problems. So what can you do that's going to be effective and safe and appropriate? And navigating all of that, our expectations, their expectations. So there's that. So there's that stuff.
The decision making you touched on around the whole sort of, do you move or do you not move? How far do you? How far do you go?
So and when people come into hospital, so I know our social worker. This is one of those interesting stories. So the social worker who was here when I first started was here before the palliative care inpatient unit was built, when it was completely just a community service. And so they had probably a lot more end-of-life stuff being done in the community by that community team back then. Now we have this beautiful new inpatient unit. And the truth is, people like it. People actually like coming here. Families like having their patients here, including Aboriginal families. And often, sometimes we'll have an old person sitting on the bed going, I want to go home, I want to go home. And the family's going, no, you stay here. It's too hot at home. Or whatever, for whatever reason, they like being here. They like the care. And so that social worker said to me, and made me feel very bad, she said, it's genocide. Every time someone doesn't die on country and comes into town and dies, it's cultural genocide. Oh, my God. But in fact, it's choice. And, we have created an option that wasn't there before. And it is a safe place, I think, for people that is kind of appreciated. So now getting people home is actually hard. It's quite a moonshot to get people home. Which doesn't mean it can't and doesn't happen, but it isn't easy. So it's been an interesting shift, I think.
Yeah, that is interesting. Well, what about What about some of the I mean, you've touched on so many, but the possibilities, the sort of the really the golden things. And I guess in asking that question, I'm thinking also around, you know, the possibilities for the red to teach the rest of Australia, around, you know, what maybe there's two separate questions, but maybe it's all rolled in one.
No, I think that is two separate questions.
Okay.
I mean, the possibilities that I'm working on at the moment are, I've been pushing this idea of a return to country project for a long time. And as I've come to understand more the reasons why it's hard for people to be at home, it's become something I can see more how it can work. But it's actually a very complicated, difficult project. But you know, I'd love to be able to get people home more, and support families better. And I think the reality is when we do send people home for end of life, there's not much infrastructure there. There's no support there. What we need is actually be able to send support with them, so it actually is more feasible. And the whole family doesn't have to relocate to town to sit with them here. But that's challenging in lots and lots of ways. So that's one project I've got on my mind. I want to set up a renal supporter care service with the renal guys. And that's something I've been talking with them about. And we're setting up, we're looking at...
Just on that, so the dialysis, you said it's a big dialysis town, Alice, or dialysis hospital, I can't remember whether, but is there, so people obviously come in, but is there a lot of dialysis, like how does the dialysis, is it working out in different communities as well, or how does that work?
Yeah, that's a big story. Okay, so how long have we got? So renal dialysis, interestingly,
the Reader's Digest version.
They didn't, for a long time, they didn't dialyse people in Alice Springs at all. They said dialysis was not a suitable treatment for traditional Aboriginal people. And it was only in about the 90s that it actually started. And so once they started dialysing people in town, people were stuck in town, couldn't go back to their communities anymore, which still happens to some extent. But then Purple House came along. So Purple House is a Aboriginal community-controlled organisation, which has been working on, originally they started with just getting people home for visits with a dialysis truck. So people might be familiar with the purple truck. But now they're actually setting up a huge kind of network of remote dialysis chairs, basically, permanent chairs. It's an incredible piece of logistics and it's just completely mad. I mean, it's a mad idea. You know, the amount of water that's required for dialysis for a start, you know, and doing dialysis in these places is just like, it's a mental suggestion, but they've just gone and done it. It's just beyond genius. So it's an incredible thing that they're doing, but it's very, very complex to manage. And we work pretty closely with Purple House, and they're probably our partners in this Return to Country project for their dialysis patients. But yeah. So yeah, dialysis is huge here. About a third of our patients are renal patients, and the majority of those are people coming to the end of dialysis. Yeah.
Any other, and I interrupted you, any other projects or possibilities that you wanted to mention?
I think we're just about to get funded to set up a bereavement network. We don't have a bereavement coordinator at the moment, but equally, I think we don't have a model for doing bereavement here. I think the model we did have when we did have bereavement coordinator was really a white bereavement service. Yeah. So we've actually just about to get some funding now to set up a network, which will actually network with the ARCHOs and some of the other mental health services in town, and actually start to develop much more inclusive models about how we provide bereavement care. So that's
amazing. That sounds amazing.
Yeah, well, I hope it will be. Yeah. So we're partnering with an organisation, and we're going to kick that one off really soon.
And what things do you see that you think, gosh, this should translate to the rest of Australia? We should be doing it like, everyone else should be doing it like this. Everyone else should learn from this. What are those things?
I think it's about being not siloed.
Yeah.
I think the fact that we are a single team, that we are very hands-on with our care, we're able to be very flexible with who we have in our service and how we provide our service to people. It allows us to really meet people's needs. And we are really fortunate. We don't get a lot of pressure from the hospital about length of stay, that sort of thing. So we are able to really, or multiple admissions. So we're really able to offer people an incredibly flexible care and really be there with them. So that flexibility and just able to really be the service that our patients need us to be, and between our whole team, share that together, share all the knowledge about the patient and share the care of the patient. It just works really, really well. And I think when people come here for a visit and locum, they kind of go, oh my God, I love doing this, because it just means you can actually be there when you're needed. Like our on-call service just works superbly. It's a bit tiring, but it's it makes the whole service work. It actually makes the hospital work in a way too, because we can get our patients to where they need to be at the right time without any delays. So yeah, we've been really, really lucky, and I think that's what I would miss if I went and worked anywhere else. Yeah.
Well, that's a big thing that we should just rediscover, isn't it? I don't know. Maybe not rediscover, maybe discover. Yeah. Thank you. So, Christine, tell me what gives you joy.
Being alive every day. Seriously. No, I have rediscovered a lot of just sheer pleasure in life and in work since I've been here. And I love my work a lot. And I must admit, I've sort of thrown myself into it. But living here is wonderful. Like, there's a lot of pleasure just from being here physically. Where I live is the most beautiful place. The physical environment, the animals, just being out in the fresh air and out of town is just, it's fantastic. Just love life here.
Yeah.
My husband and I just always look at each other and go, geez, this is nice. Wish we'd come here earlier. It's a very lovely place to live.
It's so beautiful.
It is.
Sorry. So we normally finish on asking you to comment on a quote, and
I didn't know I had to comment on the quote.
Oh, okay. Would you like to comment on the quote? You don't have to.
I can comment on that.
Okay. So the quote that we've chosen is from Nelson Mandela, which is, "May your choices reflect your hopes, not your fears." Thoughts on that?
I just think you have to be optimistic and just grab the moment. So it's always about the hopes and not the fears. If you, like, what else can you learn from being a palliative care doctor? If you can't learn that, you just got to grab those hopes and go with them. And every day, got to make every day count, because there might not be another one. So, and you will have fun along the way if you do it that way, I reckon.
Well, we can see that. It's been a glorious conversation, Christine. Thank you. So thank you so much for sharing and for being who you are, and I admire and commend your courage and your commitment, and also just rejoice in the joy that you have in your work and in life, in the things that you see and the people that you serve. So thank you for sharing some of your reflections this afternoon, and I would like to say thank you to our audience for joining us, and there's lots of little clapping hands coming up.
Am I allowed to say one more thing? Is there a second?
Please, no. Yes, no.
If people are interested in working rurally, they should just put their feet into it. They should just go for it. It really is incredibly rewarding. And if anyone wants to come and work here, they should get in touch too. We need more people who can share that pleasure. I think it's a really good thing to do to get out of town.
Well said, and thank you for sharing your pleasure this afternoon. It's really been fun. And thank you to Georgia, and particularly also to Tanya, who organises this all and corrals us and shepherds us all in the right place and makes all these things happen. So I hope that everyone has a lovely afternoon and evening. And once again, thanks, Chris, and
thank you, Jen, too.
everyone. Okay.